Imagine a condition that affects hundreds of millions of people, silently altering the chemistry of their blood in a way that slowly turns their own vessels against them. For decades, we treated this condition by focusing on a single number, blood sugar. But here is the strange reality that puzzled doctors for years. You could lower that number, yet the patients would still face life-threatening heart events at staggering rates. Why was fixing the sugar not fixing the heart? Today in this video, we are diving into a massive clinical research effort known as the SOUL trial, a study designed to answer whether a specific, innovative pill can do what was once thought impossible: bridge the gap between controlling diabetes and physically protecting the heart from catastrophe. To understand the gravity of the trial at hand, we must first zoom out to the global landscape of type 2 diabetes. This is not just a disease of blood sugar. It is a systemic metabolic disorder that currently affects over 500 million people worldwide. But here's the statistic that keeps cardiologists awake at night. The leading cause of death for people with type 2 diabetes is not a diabetic coma or kidney failure, it is cardiovascular disease. In fact, if you have type 2 diabetes, your risk of having a heart attack or stroke is 2 to 4 times higher than someone without it. But here's the part most people don't talk about, and it's crucial to understanding this study. For a long time, medical science operated under a glucose-centric model. The thinking was simple. High blood sugar is the poison, so lowering blood sugar is the antidote. We developed drugs like sulfonylureas and injected insulin that were incredibly effective at smashing down glucose levels. But when we looked at the long-term data, a disturbing pattern emerged. While the sugar levels dropped, the heart attacks didn't stop. In some infamous cases in the history of medicine, certain aggressive sugar-lowering treatments actually increased the risk of dying. This phenomenon created a crisis of confidence in the medical community. It revealed that the biology linking diabetes to heart disease was far more complex than just too much syrup in the blood. So what is actually happening inside the vessels? When a person has type 2 diabetes, it's not just that their glucose is high. They often have a condition called insulin resistance. Their cells stop listening to the signal to take up fuel. In response, the pancreas pumps out more insulin, and the liver behaves erratically. This metabolic chaos damages the endothelium, the delicate single-cell inner lining of your blood vessels. Think of the endothelium as Teflon. When it's healthy, everything slides right past. But in diabetes, this lining becomes inflamed and sticky. This brings us to a critical concept called atherosclerosis. Because the vessel walls are irritated by high glucose and inflammation, cholesterol particles are more likely to burrow into the wall and get stuck. The body's immune system attacks these stuck particles, creating a plaque, a pimple-like pocket of fat and dead immune cells inside the artery. Over time, this plaque hardens. But the real danger isn't just the blockage, it's the rupture. If that plaque bursts, a clot forms instantly, blocking blood flow to the heart or brain. This is the mechanism behind a heart attack or stroke. This raises an interesting question about how the body responds to treatment. If lowering sugar alone doesn't fully stop this plaque buildup, what will? This is where the concept of cardiovascular outcome trials, or CVOTs, comes into play. Regulators realized that new diabetes drugs needed to prove they didn't harm the heart. But scientists began to wonder, could we find a diabetes drug that actually heals the vessels or stabilizes these plaques, independent of just lowering sugar? This search for a dual-purpose therapy, one that treats the metabolism and the cardiovascular system simultaneously, is the driving force behind the research we are analyzing today. In this study, researchers are testing a medication called oral semaglutide. To appreciate why this is a scientific feat, we need to understand the molecule itself. Semaglutide belongs to a class of drugs called GLP-1 receptor agonists. GLP-1, or glucagon-like peptide 1, is a natural hormone produced in your gut. When you eat a meal, your intestines release GLP-1. It travels to your pancreas and says, preparation is needed, release exactly the right amount of insulin to handle this food. But it also does something else. It tells your brain, we are full, stop eating, and it tells your stomach, slow down digestion. This natural hormone is brilliant, but it has a major flaw as a drug. It is destroyed by the body in minutes. Scientists engineered semaglutide to mimic this hormone but resist degradation, lasting for days instead of minutes. This allows it to provide powerful blood sugar control and weight loss. But early research suggested something even more profound. It seemed that GLP-1 receptors are not just in the pancreas. They are also found in the heart, the blood vessels, and the immune system. Activating these receptors seemed to reduce inflammation and improve the health of that endothelial lining we discussed earlier. But here's the part most people don't talk about when discussing this specific trial. Until recently, GLP-1 therapies were almost exclusively injectable. Why? Because GLP-1 is a peptide, a small protein. If you swallow a protein, your stomach treats it like a piece of steak. It attacks it with acid and enzymes, chopping it up into amino acids before it can ever reach your bloodstream to do its work. For decades, the holy grail of diabetes research was figuring out how to sneak a peptide drug past the stomach's defenses in a pill form. The intervention in this trial, oral semaglutide, utilizes a fascinating piece of chemical engineering called a permeation enhancer, specifically a molecule known as SNAC. When a patient swallows the tablet, the SNAC molecule essentially creates a temporary, localized buffer zone in the stomach. It neutralizes the acidity in just the immediate area around the pill and makes the stomach lining slightly more permeable for a few moments. This allows the semaglutide to slip through the stomach wall and into the blood intact, bypassing the digestive destruction. The researchers in the SOUL trial are not just testing if this pill lowers blood sugar. That is already known. They are testing whether this oral formulation, taken once a day, translates into a tangible reduction in major heart catastrophes. They are hypothesizing that the drug will do more than control diabetes. They believe it might fundamentally alter the progression of cardiovascular disease in high-risk patients. This raises an interesting question about the consistency of biology. We know the injectable version of this drug protects the heart, but does the oral version, which enters the body through the digestive system and passes through the liver first, a process called first-pass metabolism, have the exact same protective benefit, or does the route of administration change the outcome? This is the nuance that necessitates a trial of this magnitude. Now, let's unpack the design of the SOUL trial itself. This is a Phase 3 clinical trial. In the world of medical research, Phase 3 is the final, rigorous hurdle before a treatment can be widely accepted as a standard of care for a new indication. It is designed to be large enough to detect rare side effects and robust enough to prove effectiveness beyond a shadow of a doubt. The trial recruited a massive cohort, approximately 9,650 participants. But they didn't just pick anyone with diabetes. They specifically looked for individuals who were at high cardiovascular risk. To get into this study, a participant generally had to be over 50 years old and have established cardiovascular disease, meaning they had already suffered a heart attack, stroke, or had symptomatic peripheral artery disease, or they had chronic kidney disease. Why recruit only the sickest patients? This is a standard strategy in cardiovascular trials, known as event enrichment. If you study healthy 20-year-olds, you might have to wait 50 years to see who gets a heart attack. By studying older patients who already have damage to their vessels, researchers know that statistically, a certain number of heart events will happen within a few years. This allows them to see if the drug reduces that number compared to a placebo in a reasonable time frame. The study is randomized and double-blind. This means that of the 9,650 people, half were assigned to take the oral semaglutide tablet, and the other half were assigned to take a visually identical placebo tablet. Crucially, neither the patients nor the doctors knew who was taking which pill. This blinding is essential. If a doctor knew a patient was on the active drug, they might subconsciously treat them differently or monitor them less aggressively. Blinding ensures that the only difference between the two groups is the molecule in the pill. But here's the part most people don't talk about regarding how success is measured. The researchers aren't just measuring blood sugar or cholesterol levels. Those are surrogate markers. Instead, this trial is event-driven. The primary outcome measure, the main yardstick for success, is something called MACE. This stands for Major Adverse Cardiovascular Events. MACE is a composite endpoint, essentially a bucket that includes 3 specific tragedies. 1, cardiovascular death, dying from a heart issue. 2, non-fatal myocardial infarction, a heart attack that doesn't kill you. And 3, non-fatal stroke. The trial continues until a specific number of these events has occurred across the entire group. Once that number is reached, the statisticians unblind the data. They count how many MACE events happened in the placebo group versus the semaglutide group. If the semaglutide group had significantly fewer events, for example, if 500 people on placebo had a heart attack, but only 400 on the drug did, that proves the drug has a protective effect. The researchers are also looking at secondary outcomes. These act as supporting evidence. They are tracking all-cause mortality, did the drug help people live longer in general, the time to the onset of worsening kidney function, and specific changes in blood vessel health. They are effectively asking, does treating the whole system with this metabolic regulator prevent the body from breaking down? This raises an interesting question about the duration of such a study. Unlike a study for an antibiotic, which might last a week, a cardiovascular outcome trial like SOUL must run for years. Participants in this trial are followed for up to 5 years. This long duration is necessary to see the chronic effects of the treatment. Atherosclerosis is a slow process. Reversing it or stabilizing it takes time. A drug might show no difference in year 1, but a massive difference by year 3, as the cumulative benefits of healthier vessels add up. So, what are the implications of a trial like this? We have to look at the potential scenarios and what they mean for the future of medicine. In the best-case scenario, if the SOUL trial shows a significant reduction in MACE, meaning fewer heart attacks and strokes, it represents a paradigm shift in accessibility. While injectable GLP-1 drugs have shown heart benefits, injections can be a barrier. Some patients have needle phobia. Others find the storage and handling of pens cumbersome. An oral pill that offers the same high-level heart protection as an injection would democratize this benefit. It would allow primary care doctors to prescribe a heart-protecting diabetes treatment as easily as they prescribe a statin or aspirin. It would confirm that the molecule itself, regardless of how it enters the body, is a cardioprotective agent. But here's the part most people don't talk about. What if the results were neutral? In the context of diabetes safety trials, a neutral result, meaning the drug didn't prevent heart attacks but didn't cause them either, is actually still a passing grade for safety. For years, the FDA simply required that diabetes drugs not harm the heart. However, given the high bars set by injectable versions of this drug class, a neutral result for the oral version would be scientifically fascinating but clinically disappointing. It would suggest that perhaps the first pass effect through the liver alters the drug in a way that diminishes its cardiovascular potency compared to the injection. This would teach scientists vital lessons about pharmacokinetics, how the body processes drugs. Even a negative result, where the drug performed worse than placebo, which is highly unlikely given the class history, would be incredibly valuable. It would force a complete rethink of how we formulate oral peptides. It would suggest that perhaps the absorption enhancer, SNAC, has some unknown interaction. In science, every result, whether positive, negative, or neutral, fills in a blank spot on the map of human biology. Currently, the medical community is moving toward a cardio-renal-metabolic approach. We are stopping the practice of treating the heart, kidneys, and sugar as separate problems. A successful outcome from the SOUL trial would cement oral semaglutide as a foundational pillar of this new holistic approach, potentially updating treatment guidelines worldwide to recommend this specific oral therapy, not just for glucose control, but specifically to save lives in high-risk populations. When discussing a trial of this magnitude, involving nearly 10,000 people, we must discuss the rigorous safety and ethical framework that surrounds it. Clinical trials are not the Wild West. They are the most highly regulated environments in medicine. First, let's talk about the specific safety signals researchers are monitoring in the SOUL trial. Because semaglutide affects the gut, gastrointestinal issues are the most common complaint: nausea, vomiting, and diarrhea. While usually not dangerous, these can be unpleasant enough to make people stop the medication. The trial monitors these events closely to see if they are sustainable for long-term use. But there are more serious, rare risks that are under specific surveillance. One is diabetic retinopathy complications. In a previous trial of injectable semaglutide, called SUSTAIN-6, there was an unexpected finding. While the heart got better, a small number of patients saw a worsening of their diabetic eye disease. Scientists believe this might be due to the rapid drop in blood sugar affecting the tiny vessels in the eye. Because of this historical signal, the SOUL trial includes rigorous monitoring of eye health to definitively answer whether this risk is real for the oral version and who is susceptible. This raises an interesting question about how safety is ensured in real time. How do we know the drug isn't harming people during the 5 years of the study? This is the job of the Data Monitoring Committee, DMC. The DMC is an independent group of experts, statisticians, cardiologists, and ethicists, who are not involved in running the trial and represent the only people who are allowed to see the unblinded data while the trial is ongoing. They meet periodically to look at the numbers. If they see a clear signal that the drug is causing harm, they have the power to stop the trial immediately to protect the participants. Conversely, if they see that the drug is overwhelmingly effective, so effective that it would be unethical to keep giving the placebo group a dummy pill, they can also stop the trial early to offer the treatment to everyone. This stopping rule ensures that participant safety always takes precedence over scientific curiosity. Furthermore, every participant in the trial goes through a comprehensive informed consent process. They are told exactly what the risks are, they are told they can withdraw at any time for any reason, and they are closely monitored by study physicians, often receiving a level of medical attention far superior to standard care. This ethical oversight is the bedrock of modern clinical research. To summarize, the trial is more than just a test of a diabetes pill. It is a massive scientific inquiry into whether we can protect the human heart from the ravages of metabolic disease using an oral formulation of a natural hormone mimic. It represents the culmination of decades of research into insulin resistance, endothelial health, and peptide engineering. By studying nearly 10,000 patients over several years, this study aims to provide definitive evidence that could change how millions of people manage their health, moving from simply managing sugar to actively preserving life. Whether the results show a massive benefit or a neutral safety profile, the data generated by the SOUL trial will be cited in medical textbooks and treatment guidelines for years to come. As with all scientific progress, the story is written in the data. Research like this is ongoing, and our understanding of these mechanisms evolves with every study published. This video is for informational purposes only and does not provide medical advice.